What I was asked to talk about was COVID and heart and the devil within, and to focus on some of the cases that would illustrate all what Dr. Anil has been talking about. And so, without any ado, let me go there. Now, we do know that commonest clinical presentation for a COVID who gets hospitalized is respiratory, which happens to be in two-thirds of cases. But interestingly, cardiac is the second most common complication, and it happens in about one-fourth of the cases. But not only the incidence, but in those people who have heart disease due to COVID, the mortality is higher. As a matter of fact, I think interesting point is that even in recovered patients who go home, cardiac involvement is often masked. And if you look at these figures, one autopsy case analysis of patients dying of COVID disease found COVID virus in myocardium in 41% of cases. More importantly, even in people who had COVID disease and had no obvious cardiac involvement, there were MRI abnormalities in 78% of the cases, and there was an ongoing myocardial inflammation in 60%. Increased troponin levels were found in 72%. So, even if there is no obvious cardiac disease, if you do MRI, then you would find evidence of COVID disease in more than three-fourths, and in more than two-thirds have some echo findings in patients who come for get admitted for COVID disease. Interestingly, RV dilatation is the most common finding, and the cause of RV dilatation has been discussed. It could be because of pulmonary embolism. It could be because of hypoxic pulmonary vasoconstriction. It could be because of decreased lung volume available due to presence of collapse due to pneumonia. Increased PEEP in pneumonia itself can lead to, cause RV dilatation, hypercarbia, use of alpha agonists, and LA pressure due to left-sided cardiac lesions. So these are all the causes for RV dilatation, and you can see it is present in about 40% of the cases of people of COVID disease who just get echocardiography undertaken. Other things are LV diastolic dysfunction about 16% and LV systolic dysfunction in about 10% of the cases. So really, majority of the patients, more than two-thirds, have some echo finding if you care to do echo in a person who has got COVID disease. Now, the spectrum of clinical cardiac manifestation is a bit different, from the asymptomatic cardiac disease. There could be acute presentations and there could be long haulers. And this is an interesting term in context with COVID, which was also present with other SARS infections, which happened in 2003. Among the acute presentations, the common ones are, of course, acute coronary syndrome, acute myocardial infarction, myocarditis, also Takotsubo cardiomyopathy, rhythm disturbances, and of course pulmonary embolism that I already alluded to. In the long haulers, I think the basic complications arise from immunothrombogenicity, what Dr. Anil was already describing, which persists long after the virus has gone away. So the increased thrombogenity or immunothrombogenity persists long after the virus has even gone away, and this was also found in other SARS infections as well in the past. And the thrombosis could be arterial, which could lead to, after discharge, occurrence of myocardial infarction or acute coronary syndrome, or it could be venous, even venous thrombosis could lead to worsening of AF and complications associated with AF and prostatic valve thrombosis. So I will like to, show you some of the cases which will bring out my point, and then of course we can have a discussion. So coming to the acute presentation, I just present the first case. It's a 47-year-old male presented with acute chest pain at night, 8:15, breathlessness and sweating. There were no risk factors except cigarette smoking, but he was a resident in COVID red zone. So at that point, you remember in the early in the COVID disease, the zones were divided. Some were red zones where you could not go out and you were kind of uh, mm, mass quarantined in that area. And so this person belonged to that. And this is the ECG. So you can see that there is bradycardia, and there is also myocardial infarction. So patient actually really reached our emergency department at about 8:45 p.m. with a pulse rate of 36 per minute, blood pressure 110 by 70. A diagnosis of anterior MI was made. The window period was 30 minutes. And the COVID had just started. So we had initially thought that we will do a thromboinvasive strategy for COVID patients, pharmacoinvasive strategy. So he was even immediately given IV atropine and also thrombolized with tenecteplase within 10 minutes of arrival. It was also thought that since the patient is in golden hour of the MI, which lasts up to at least 1 hour, the thrombolysis might itself be enough. And RT-PCR for COVID was undertaken and sent. Well, after thrombolysis, actually at 9:30, patient became drowsy and collapsed with a pulse rate of 116 per minute and developed hypotension. ECG at that time was suggestive of VT. So multiple DC shocks were given, and the VT was converted into NSR, but again patient reverted into VT. So more DC shocks were given, and patient was put on injection lignocaine and amiodarone. But despite all this, episodes of VT recurred and actually degenerated into VF. And at that point of time, at 9:30, pulse and BP became unrecordable. So CPR was immediately started, but there are special ways of doing CPR. There is in a COVID suspect patient or COVID known patient. So those guidelines were followed, and patient was intubated again following those same SOPs. Multiple shocks were given, and then patient was taken to a dedicated cath lab for COVID patients. So in our hospital, we have dedicated an area which we call the red zone, which is for the COVID known patients. And it also has a cath lab, which of course we desanitize every time the case is done. But that is a dedicated cath lab for COVID known or COVID suspect patients. So patient was shifted to cath lab on ongoing CPR. With ongoing CPR, angiography was undertaken with full personal protective equipment and other equipments and sanitization. Even lead is, we have a special lead only for this purpose, which is of course desanitized after every procedure, but we keep even lead gowns for this kind of thing. Other things are disposable. The angiography revealed ostial LAD occlusion. Flow was achieved in LAD at 10:05. DS was placed, and then patient, because we still did not know whether he was COVID positive or negative, patient was shifted into the yellow zone awaiting the COVID confirmation. Meanwhile, next day the COVID came out positive. So at that point of time, patient was shifted to a dedicated COVID facility, which happens to be trauma center of our All India Institute of Medical Sciences. So he was shifted there in the dedicated COVID facility, and the ward he was there in the yellow zone was completely, sanitized before taking in any more patients. Meanwhile, patient remained stable in the special COVID facility, and he was mobilized in the usual manner and discharged from COVID facility in a stable condition on DAPT. So, what are the take-home messages with this particular case? Now, COVID, due to increased thrombogenicity and increased matrix metalloproteinase secretion and also mental stress, is a potent aggravator and can precipitate plaque rupture, which leads to rather aggressive type of acute coronary syndrome because of increased thrombogenicity as well. So I think here we need not, we have to little bit deviate from the guidelines where we think that thrombolysis can be done in golden hour, and probably are towards doing primary PCI kind of situation, because the patient happens to have more aggressive kind of ACS, which may not very easily respond to thrombolysis. Otherwise, the principles of treatment of ACS remain same, and primary PCI, as I already discussed, seems to have the better outcome. The treatment of ACS and AMI cannot be delayed because of uncertainty about COVID status. And I think that is very important, that we should take care that we carry out our best therapy or standard therapy without waiting for the COVID status. Only thing is that we need to have some dedicated areas, for example, cath labs, waiting areas, ICUs, wards, which should be designated separately for COVID patients and COVID suspected patients. And if you see on the right side, this is a typical hospital which has been divided into 3 zones. The yellow one is the COVID suspect area, the red zone is COVID known area, and the green zone is possible COVID free area. So these are the 3 areas. Until we get the final confirmation of COVID in or out, I think patient has to be kept in the yellow zone. And the therapy, as I discussed, should be undertaken with full precautions for both the healthcare workers as well as other patients who might be there in the waiting areas, etc. So all those precautions should be taken, protective personal equipments, SOPs, and special areas for COVID work. Now, coming to the second case I'd like to present, it was a 25-year-old girl. She presented with evidence of dyspnea on exertion class 3, which became class 4, but there was no history of fever, no chest pain, slight hypotensive, as you can see, and tachycardia, and tachypnea as well, and oxygen saturation was 92% on room air. Otherwise, there was S3 murmur, S3 sound, and bilateral basal crepitations. This is the ECG, and you can see that there is evidence of sinus tachycardia. X-ray is also not much helpful. I mean, showing you that there is no patch, at least on X-ray, for suspecting lung abnormalities. Hemoglobin slightly on the lower side. These are the reasons, but the patient turned out to be COVID positive. And there was a slight elevation of troponin, elevation of BNP, also slightly hypothyroid. D-dimer were elevated. So it showed ongoing immunothrombogeny in this patient with COVID infection, and probably that was the reason for her situation. Echo showed global hypokinesia of both LV and RV types, actually. Ejection fraction being about 20%. LV on the upper limit of normal, moderate MR, probably functional. Moderate TR also, again, probably functional. RV slightly dilated, and mild circumferential pericardial effusion. So basically, on the basis of this, all this, a diagnosis of myocarditis was made, which the confirmatory test, of course, for myocarditis is cardiac MRI, and which showed LV dilatation, mild RV dilatation as well. The important thing that we saw on MRI was subepicardial enhancement and subepicardial scarring, which is diagnostic of myocarditis. I mean, not diagnostic, but highly suggests myocarditis at least. And this was the picture. So a diagnosis of myocarditis was made. Now, how to treat myocarditis? That is the question. Of course, in this patient, because there was hemodynamic alteration, hemodynamic monitoring is necessary. Radial line, Swan-Ganz catheter for wedge pressure, weight, and urine volume estimation. Inotropic support was also required because, as you might remember, blood pressure was slightly on the lower side. IV dobutamine happens to be the best drug, with the aim to achieve a systolic blood pressure of at least 100 and mean arterial pressure of 65 with good urine output. So all that was given. More importantly, patient has got electrolyte imbalance. There is a dilutional dyselectrolytemia, hypervolemia, hyponatremia, and hypokalemia. For this, fluid restriction is the best thing, to restrict less than 1 liter, trying to achieve a pulmonary wedge pressure of about 14, but also requiring some potassium supplementation orally, and diuretic therapy, 2 milligram per kg furosemide. ARBs and vasodilators were also started once blood pressure picked up to more than 100 millimeters systolic blood pressure. Since saturation was 92%, oxygen was also required by NIV, and low molecular weight heparin was also started in view of her thrombogenic condition and risk of developing other complications. Immunosuppressant therapy was also started as a specific therapy for immune dysregulation, and also as an anti-inflammatory agent. IV methylprednisolone 500 mg per day was started, and immunoglobulin 80 mg per day was also started. Uh, Antiviral therapy, specific antiviral therapy, as you might remember at that point of time in the early during the course, it was thought that hydrochloroquine could be a good idea as an antiviral agent. So she was indeed started on HCQ therapy, 400 mg. This is the usual dose. And by that time, remdesivir had also come, and so that IV dosing, loading, and maintenance dose was also started, specifically addressing the COVID infection. Now, patient, of course, with all this became comfortable. Hemodynamics improved, as saturation improved. There was no acidosis on ABG, blood pressure improved, and we could taper off the NIV pressure support. But look, the biomarkers are actually on the worst side. So troponin levels have increased, CKMB levels have increased, and BNP level has also increased. So this was a bit worrying, but we thought everything is, patient was symptomatically better, other things had improved. So patient was sort of kept on this therapy, but that was, I think, a kind of wrong decision, because the very next day patient developed persistent orthopnea with increasing oxygen requirement. Patient got intubated and put on mechanical ventilation. Patient also developed hypotension with decreased urine output, although there was no fever, and ABG suggested marked acidosis and hypoxemia. And you can see all the lab investigations also worsened at this point of time. And so patient was really bad. So what next? Now, in this particular case, we know that the hemodynamics have worsened. The ventilatory parameters are also not working. So we need to do two things. First of all, we have to provide a cardiac assistance, a strong cardiac assistance. And second, we have to little bit work more on the antiviral therapy. So regarding the cardiac assistance, we decided to put her on ECMO, a VA ECMO, and also, we modified the dopamine and added noradrenaline as well, and put on higher type of antibiotics. Remdesivir was continued, and we also started more anti-inflammatory agents like azathioprine 100 mg in addition to corticosteroid, and convalescent plasma therapy was also given. So with all this, actually, finally patient improved. ECMO initiation led to decrease in inotropes. Ventilation was weaned off after some time. Patient was decannulated from ECMO as well on the 12th day. Another 2 days, patient was weaned off from mechanical ventilation completely. In a hospital, cardiac function improved, and there was near normalization by about 28 days when patient was discharged with full clinical recovery. But patient was instructed not to undertake any heavy exertion for 6 months and repeatedly follow up for echocardiography. So this was what we did. So what are the messages from this particular case? Number one, diagnosis of COVID myocarditis is not straightforward. It can mimic myocardial infarction, idiopathic dilated cardiomyopathy, arrhythmogenic disease. In this case, because she was a girl, 25-year-old individual, and rapid onset, so we were relatively certain. Cardiac MRI is the gold standard, and the diagnosis is made on epicardial mid-wall inflammation and subepicardial scarring. The course of disease should be monitored by the cardiac enzymes, increasing or decreasing, and other inflammatory markers. Echocardiography and even cardiac MRI may be done in case of myocarditis. Treatment of myocarditis is antiviral, immunosuppressive, remdesivir, and plasma therapy, plus supportive for heart failure, and symptomatic, and if required, even cardiac assist device. Sick patients require cardiac assist device, which can help them. So now coming to the second variety, where people have recovered, gone home, but they harbor the disease still, or they harbor at least the pathogenic mechanisms. The immunothrombogenic phenomena continues, and what can happen? So here was a gentleman, 45-year-old bureaucrat, diabetic, hypertensive, developed mild COVID infection, loss of taste, flu, etc., with good saturation, and therefore advised home isolation. And within home, completely recovered within a week, turned COVID negative on 14th day, and after that he joined his work. So he was like somebody who will call nearly asymptomatic COVID disease. Started going work after 2 weeks, but few days later, while at home after dinner, he developed severe chest pain, sweating, difficulty in taking breath, rushed to our hospital 10 p.m. And you can see it showed evidence of inferior myocardial infarction with a window period of 45 minutes, Philip class 1. Now, within casualty, patient had sudden cardiac arrest, and on monitor we saw VF. We gave DC version, brief CPR, 300 mg amiodarone given, and this is the ECG that this patient had at that point of time. So we decided to do a PCI. Patient was again developed in between. He by the when we had decided to do PCI, but before shifting him, patient got better and then again went into VTVF, was again given CPR, reached cath lab on arrival, again had VF there, and we started the PCI on CPR. Right angiogram was done. I don't know why it's not playing, but it was showed a blocked RCA. So primary PCI was done, RCA was opened with a good result. Maybe if I have time, I will show you the final result at the end of this presentation from the clip itself. And meanwhile, while we have very sick patients, what we do is one set starts doing the PCI and the other stats start working to put a assist device, in this case IABP. So by the time actually the PCI was done, the IABP was also on, and therefore the left injection was done on IABP support, which was achieved simultaneously. And then patient was shifted to the CCU facility now because already COVID free now, had past history of COVID, so he was kept in the green zone, and he was 6 hours. He became conscious, tapered off IBP, extubation done next day, and mobilized the next day, and then discharged on day 4 in ambulatory condition like any regular patient, just with evidence of mild LV dysfunction, ejection fraction of 50%. So what are the take-home messages? So I think important to realize that cure of COVID is not end of the story, because there may be some pre-existing disease which may get unmasked, and some new diseases may actually appear, like because of increased thrombogeneity that's already present. So end of viremia does not completely normalize the microenvironment. There was complete increased continuing inflammation, continuing immune dysregulation, and thrombogeneity may persist. But the main question is how to monitor for these long haulers. So what can we do in a regular COVID patient to monitor them, to decide whether they are the long haulers and whether they need to be do something, and if then something is found, then what to do, how to treat them. So for monitoring, I think with known COVID patients, a repeated follow-up echos is a good idea. The D-dimer estimation is also important. If it is more than 1,000, then maybe you can think that this person is high risk for developing thromboinflammatory complications. HRCT, if pneumonia is there, in many cases actually does not resolve for a few weeks after the thing, and MRI if already known cardiac disease is present. But the therapy, as already discussed, generally venous thromboembolic prophylaxis is not required unless you think somebody is very high risk, and that is what Dr. Anil also told us. And but also careful review. But what we can do is, if somebody is known cardiac disease, careful review of antithrombotic and anticoagulant therapy is mandatory to decide whether we need to increase or decrease the dose of antithrombotics or anticoagulation. But routine ASA or P2Y12 therapy is not indicated. Finally, the last case I will show, a 39-year-old female with known case of adult CHD, TOF, post-total correction, residual VSD had, then another surgery, post-trans RAVSD closure with a prosthetic valve in the pulmonary position, a Chitra mechanical valve, and on acetrom. Now, this patient developed COVID pneumonia in December 90, relatively recently, admitted in our COVID facility, had a short episodes of SVT, which was reverted with adenosine, metoprolol, and diltiazem. And we discussed that they commonly have some rhythm abnormalities. Started on amiodarone, discharged on amiodarone, acetrom, and metexel, acetrom 2 milligram. Now, you would think everything is all right, but 2 weeks later, patient developed hemoptysis, shortness of breath, NYHA class 3, abdominal distension, and she gave a history of irregular intake of oral anticoagulants. Otherwise, she was stable. And
you to hasten, please.
these are the lab investigations. I will quickly run through. ECG was generally normal, X-ray was also normal, but CT showed that there were few GGOs, and residual echo showed that same thing, residual GGO, but pulmonary valve, prosthetic heart valve thrombosis with a gradient of 50/30. So a diagnosis of prosthetic valve thrombosis was made, severe RV dysfunction. Now we not naturally thought it was COVID-induced coagulopathy. INR was less than 2. Despite the regular, we should have increased the dose of acetrom before discharge. And so TPA was given. There was persisting shock. So another dose of TPA was given, 25 milligram, and the patient improved after that. So finally, my last slide. What are the mechanisms of disease in COVID? So there can be many mechanisms, and I think Dr. Anil told us some of them. So there is a direct viral disease. There is, of course, dysregulation of immune system. There could be decreased immunity, which can lead to fulminant viral infection, or there could be increased immunity with cytokine storm, which is probably the most common cause of organ damage with COVID disease. But there could also be unmasking of previous disease. So patient may be asymptomatic, for example, present with lung disease, also have some myocarditis, and you know that about 78% of people have evidence of MRI abnormalities, and that once the patient starts mobilizing, that cardiac manifestation can get unmasked. And of course, there could be increased thrombotic tendency. We already discussed the causes. But also not only cardiac problems, there could be some neurological problems as a result of this immune dysregulation, inflammation. There could be delirium, cognitive difficulties, confusions. There could be chronic fatigue. But there could be some side effects of acute treatment also, especially NSAIDs, which can cause some side effects. So finally, to conclude, heart is a frequent site of involvement. MRI shows 78% involvement, echo 68% involvement, increased troponin elevation in 72% of the cases. Cardiac is the second most common clinical presentation after respiratory. Cardiac presentation can be acute, or they could be long haulers. Acute presentations are ACS, myocarditis, Takotsubo cardiomyopathy, rhythm disturbance. I showed you some of them. And there could be arterial and venous thrombosis. Thank you so much for your kind attention.